You're watching the India Development Debate with me, Tamanna Inamdar. Now, over the last many days on the show, we've been talking about how important it is to open up. The first hesitant steps we're taking across the country to opening up the lockdown. But we also must look very closely at a very, very big challenge we're facing, especially in our large cities. Over the last few days, you've probably been hearing on the news anecdotally and from people you know how dire the situation is in our national capital in Delhi. Whether it is getting a simple COVID test, if you test positive and need hospitalization, whether it is getting a bed, and then, of course, finding doctors and nurses to treat you. We saw something similar in Mumbai, and the situation in Mumbai also continues to be dire. Many questions come to mind. One is that after over 70 days of lockdown, why are we still not in a position to have made our health infrastructure strong enough to deal with the numbers that we knew were coming? These numbers were projected. More so, we do today have projections within governments, and there are many experts out there who are putting out projections of how fast the numbers will grow. Is there any kind of solution in sight? Is anyone even working towards ensuring that we have enough doctors, beds, care? Why is it all seeming so haphazard? Why are local administrations responding by wanting to then centralize and control and hit price caps on whatever infrastructure actually exists? We know what happens when there is one power centralizing access to healthcare. Usually, it's the rich, affluent, and influential who get through. Right now, even those are struggling. So you can imagine the situation when a former union minister puts out on Twitter that he had to move heaven and earth to get his wife tested. Even if those powers don't work, you can imagine what's happening to the Aam Janta. To top it all are the projections. Let's listen in before we go ahead to what Manish Sisodia, Deputy Chief Minister of Delhi, said today after a meeting with central government officials. And here are his projections of how many cases there will be in Delhi and how many beds will be required.
15 जून तक 44,000 केसेस होंगे और करीब 6,600 बेड्स की आवश्यकता होगी। 30 जून तक 1 लाख केसेस पहुंच जाएंगे और 15,000 बेड्स की आवश्यकता होगी। 15 जुलाई तक करीब 2.25 लाख केसेस हो जाएंगे और 33,000 बेड्स की आवश्यकता होगी और 31 जुलाई तक करीब 5.5 लाख केस पहुंच जाएंगे दिल्ली में और उसके लिए करीब 80,000 बेड्स की आवश्यकता होगी।
Nearly 80,000 beds and will have over 5 lakh patients in Delhi by 31st July. How are we going to be dealing with it? And it's not just about Delhi. I said in the beginning of the show that Mumbai is also in big trouble. These jumbo facilities are being created, but there is a lag between the number of patients who need it and who don't. Worse is the uncertainty. Today, a lot of people just don't know. Where do they go if they have symptoms? Will they get a prescription for a test? How do they get the test? What if they need a hospital? What will the hospital charge them? These answers still don't exist as clearly as they should, and that is the big issue. To speak more on this, I'm joined today by Dr. A.S. Soin, Chairman of the Medanta Liver Institute, and Viren Shetty, Executive Director and COO of Narayana Health. Welcome to both of you, and thank you for speaking with us today. Dr. Soin, I just want to start by getting your view on what's happening in Delhi and how scary the situation is. And I know it's become political, but as you may have noted, we are not getting into the politics of it at all, because I don't believe COVID-19 and how we treat it is a political issue. All governments have to perform. There's no choice.
What's happening in Delhi is pretty much representative of what's happening elsewhere in the other metros and what's happened in the Western countries when the infection rates were surging. And like you said earlier in your comment, we had over 2 months to prepare for this. And I believe we have put in some preparation. The epidemiologists, the doctors, the administration, everybody's been thinking about it. And there has been some, obviously a huge advantage in preparation. But you see, there is a physical limit to the beds and ICU beds that we can actually get. So at the moment, Delhi has about 30,000 cases and approximately the need for 8,000 beds, of which about 10 to 15% or even 20% need to be in ICU. So that's the current need. But then if the projections of 5 lakhs are going to bear out, then obviously you're going to need way more beds than are currently available. So I don't think that nothing has been done, but I think that there is a physical limit to the beds in ICUs that can become available. And therefore, there needs to be a clear flow of what's going to happen to anyone that needs a test and that needs a bed. I agree with you. Now, I think that the testing cannot be restrictive. The testing has to be widespread. Testing has to be widespread. Testing has to be according to guidelines, but then it has to also be left to the discretion of doctors. Because you see, now I go to hospital, I treat non-COVID patients for their other problems. I need to know which of them has the infection and doesn't have the infection. I have 2 corridors in the hospital. I need to find out where I need to put a particular patient. I also need to know the status of the healthcare workers because we don't want to be passing on infection to each other, to the patients and to our families. So obviously, a universal central control of testing is not feasible, it's not even advisable. Doctors need to take a call on testing. That's for one. The second thing is that who needs admission and who can have admission where. I don't think there should be geographical limitations on who can get admitted in Delhi NCR. The admission should only be governed by the sickness of the patient. If the patient can actually be at home and isolated at home or in a common isolation facility, if they don't have the facility at home, then that should be preferred. Hospital admission should be for patients who need hospitalization wherever they are from. It should not be restricted to only residents of Delhi within Delhi. I mean, people have always looked up to Delhi and come there for, treatment.
No, there's no doubt. There were 2 extremely ridiculous decisions which were taken by the Delhi government, and then they were overturned by the LG. One is on who can get tested, and one is, of course, on, only Delhiites can be admitted to Delhi hospitals. But again, these are symptoms of panic. Why do administrations take decisions like this? And it comes back to the root of what we're discussing. These are symptoms of panic when you realize that a lot of cases, not enough beds, and a lot of angry people out there. Now, Dr. Soin, you have to, hopefully you will speak very clearly about what's going on. The fact is that doctors are also sort of caught in the middle. Many people in governments don't want the numbers to go up. There is a lacuna between what is needed and what is happening.
So as I see it, unfortunately, there's a quadrangular contest or a fight. Citizens, legislators, doctors, and COVID. Whereas the other 3 have to join the fight and direct it at COVID. Unfortunately, we all seem to be at loggerheads and, the panic is basically causing the warriors to fight among themselves, which is the administrators and the hospitals and the doctors. So, we should all be on the same page and fight the war against COVID. And admissions should be given to people in private or public hospitals, depending on their clinical severity. If they can afford it, they should be asked to pay for it because the private hospitals otherwise won't be viable to run. And if they can't afford it, then yes, they should be given subsidies. I agree with that as well. And then you see, people who need hospitalization, a proportion of them, maybe 20%, 15% will need ICU. And if patients need to be shifted from outside of NCR or within NCR from one hospital to the other so that they can be taken care of at a higher level facility, that should also be facilitated. So there should be a complete, good kind of guide on how the patient flow will take place. From needing a test to needing admission to severity to public versus private, how much should be charged? If the patient can't afford it, sure, Ayushman Bharat rates or government CGHS rates should be paid. I agree with that. But it can't be across the board. You can't come into a private hospital because you like the facility there, and then even if you can pay, you don't want to pay. Or you send nasty messages on social media. That doesn't work, So you have to see both sides of the picture.
Okay, so, in defense of both sides, since we have people who run hospitals here, I'll have to take the other side of the picture. Viren Shetty, about the payments. I mean, there are also hospitals who are charging a lot because perhaps they have to subsidize the rest. and everyone wants top quality treatment. But here is a situation where you don't even know if you will get a bed. The numbers have become scary. And those who need hospitals are running around from pillar to post before they actually even get admission. In some cases, it's just too late.
So there's different categories of ICUs and there's different types of COVID patients. There are patients that are completely non-symptomatic who may be COVID positive and who can be treated with just pure medication. Then there are patients with multiple comorbidities who may be older, who may be quite, coughing and have violent symptoms and for whom you need all the care and precautions that are taken. So there is a wide variance in the costing of treating these COVID patients. And most of the time, hospitals are able to do a good enough job in explaining to patients that this thing is going to be expensive. But oftentimes in our experience, what we've seen is that patients, especially patient relatives, come into the hospital in a state of shock. And we don't blame them completely. And no matter how much counseling that we give them, and no matter how many times we say, this is difficult, it's going to be expensive, there will be a lot of treatment required, there will be a lot of blood infusion, there will be a lot of ICU care, it will cost, they may not be able to mentally process that. And once it gets over and you're faced with a large bill, then it becomes a point of massive contention. So as some organization like ours have decided that we will just cap the charges. And so we'll create a median cost so that no matter whether you spend 5 days or 50 days, on a per day basis, you're clear about how much it's going to cost you, right? Some hospitals are not able to do that because they're not able to have adequate control of the kinds of patients that we get. We're fortunate being in Bangalore, where a lot of the cases are under very well controlled, and we are very well able to plan out the patients as and when they come in. But in places like Delhi, Ahmedabad, Calcutta, where there are a large number of cases, you may not necessarily have that choice. So that leads to the sort of variance in the cost that comes in. On the cross subsidy, my last point on that is that hospitals aren't trying to make up for the losses that they have. I mean, the losses have been tremendous, but so you have to understand that PPE is something you can only wear for 6 hours a day. You can't even wear it for 1 hour without feeling terribly uncomfortable, which means people who are doing 12-hour shifts are only half as efficient. And so their manpower is doubled. Everything needs to double up. Or not just the equipment that you're using, the people that are put on the job, as well as the medicines and all of that. So things are going to cost more. And so that's where Dr. Soin made a very valid point in that we have to be very clear about the kind of patients that are there. There are patients with mild symptoms. Don't come to a hospital. A hospital is the worst place to come if you're feeling weak, if you have any other disease, because it's very likely that the symptoms will get worse. Please be at home or work with a lot of these hospitals that have tied up with guest houses, hotels, nursing homes, where you can be treated in a less intensive manner, and all you need is oxygen monitoring with the oximeter. Come to the hospital if you need ventilation.
In fact, a lot of private hospitals have started these COVID at-home packages, which have a per-day charge. I believe Medanta is one of them, Dr. Soin. And that is, an innovation, but it doesn't solve the problem when you have administrators in the picture. You spoke about, quadrilateral. And on one end of it was those in governance, whether it's the local municipal corporation or it's the local government or it's the central government or it's ICMR rules or whatever it may be. But there is an attempt to centralize and control. And I can understand where it comes from, because you don't want this to become free for all where those in the most need are left behind. But is that working out at this point? Because you're hearing everyone feeling like they aren't getting the care they need.
I agree.
Okay.
Now,
sorry.
Dr. Soin,
Go ahead.
All right.
No, Dr. Soin. The question's for Dr. Soin.
So, oh God, this becomes more difficult. Okay. So, well, the thing is that too much centralization is not going to work. You need to have guidelines, but you need to empower hospitals and doctors to do their best under the circumstances. So, like I said, there should be a clear path that every paying, non-paying, sick, not so sick patient has to chart. And that should be laid out, and the guidelines should be clear, and all the data should be submitted to the authorities. All that I agree with. But to have a central control on, you can't test this guy, you can test this person, you can't admit this person in a private hospital, this is how much this person will pay, that's not going to work. It's too big a problem for one central authority to handle. They can have guidelines, but they can't run the system like that. So I'm clearly of the view that guidelines, yes, data accrual, yes, but running has to be left to institutions.
Okay, let me just ask you another follow-up question. Now we know the numbers that are being projected in Delhi, and clearly you cannot have that many hospital beds ready by July 31st. As many as the government sites that they will need. So then what's going to happen?
So the one thing that shouldn't happen is panic at this point in time. Yes, it's necessary to think what's going to happen in the future, in the next 6 weeks, 6 or 8 weeks, when the numbers really become big. But right now, what's happening is testing is being restricted, and there is panic. And what's happening is hospitals are being burdened by non-COVID serious and urgent patients as well. So they have been continuously ramping up their COVID facility, so to speak, in terms of numbers. Initially, they said 20%. Now some hospitals have gone to 50%. There's an extent to which they can raise that, not just for economic reasons, but also for the fact that patients who don't have COVID also need treatment. So that's the restriction that the hospitals are going to face, and not just private hospitals, even government hospitals. I mean, there are follow-up patients of cancer, of organ failure, dialysis. All those guys need to come. It doesn't matter if they're coming from outside of NCR or within, So they have to be treated, and there has to be a certain number of bed strength that has to be kept for non-COVID patients as well. I mean, you're going to have a mounting death rate of the non-COVID patients then. I mean, who's going to decide about that? So I think that it's essential to have non-hospital facilities for patients who can be treated outside, whether at home or in common isolation facilities, or makeshift kind of centers where there is a doctor or healthcare worker visiting, either online or directly in person. And I'm sure these can take away half the load of the hospitals. So these facilities must be encouraged. Viren referred to them. We have such a system at Medanta, and we are actually thinking of ramping up that system of outside hospital care. So that's one of the solutions that we should look at.
Yeah, Viren, you wanted to come in on, the roles that governments need to play and local administration need to play to ensure that everyone gets the medical care they need. India is notorious for, those who don't have the means being left out, but also making sure that over-centralization doesn't choke the flow of healthcare.
Yeah, this is no single person's problem. We are all in this together. No single entity can solve this problem alone. And it is not just Delhi, it is Delhi NCR. And for the past how many ever years, Delhi has been the capital of all of North India, not just from a civics perspective. It's a capital of everything, capital of industry, capital of healthcare, capital of business, farming, factory, whatever you have. So this is all of our problem. And the only way we get through this is if we work together. Now, there's no such thing as a big problem. It's just a series of little problems. So let's address that one by one. If you're saying you need 80,000 beds, so what is the current bed strength? It may be closer to 20,000. So there's a gap of 60,000. You don't need that tomorrow because not that many patients are there that are going to fill up all those beds. And so as Dr. Soin suggested, we start triaging it and creating large facilities for patients that just need monitoring. We create oxygenation facilities for patients that require mild oxygen. And you reserve the hospitals and the private hospital infrastructure that is equipped for dealing with patients that require ICU and ventilation. And those are only for the serious cases. And it requires coordination. It requires people working together. It requires the private sector working with the government working with other governments, and all 4 states in the north working together to say, look, this is all our problem, and let's just please put aside all our political differences and realize that this is an equal opportunity disease that affects all of us together. And just say that's fine, whether it's a community-borne disease or whether it came from migrants or whether it came from China, it doesn't matter. It is here, it is among us. Let's just deal with it. Because this is a health crisis first and foremost. Now, the bed is one part of it. I would say the most glaring thing that is missing in all of this is the doctors. A bed, you just put a patient on a bed, he's not going to cure himself. There's a severe shortage of doctors that are not available no matter how many beds you end up creating. There are a huge number of students who are graduating from the DND after going through 3 years of a diploma training program. Their exams have been continuously postponed. There is no godly reason why they need to finish their final exam. They're good enough. Let's just take them in. There are enough medical residents that we can use for this because a lot of them would require this underground training and they'll be phenomenal doctors in the future. There are a huge number of people that can be qualified for nurse assistants, physician assistants. This could be a golden opportunity for us to completely revamp the way we think about medical education. rather than having it restricted to certain meccas of training that only train a select few number of doctors. This is what it has come to. We would have never, shot ourselves in the foot by announcing a nationwide lockdown if we have enough health infrastructure and doctors to be able to take care of the surge of patients that come. We're in this because we don't have doctors. So one of the chief things that needs to be addressed simultaneously with the beds and infrastructure is just get a large number of healthcare workers on the ground qualified immediately.
Well, that's a very good point there. We've not been talking about the shortage of doctors and nurses, even if you do manage to get an admission. Dr. Soin, is there enough being done to find solutions there?
I completely agree with Viren that doctors who don't normally do infectious diseases, doctors who are junior doctors yet to do their final exams, doctors in far-flung areas, everybody should be recruited to help out. So I think that we can have enough doctors. Now, you must understand that in today's day and age, you don't actually need a physical in-person doctor for every patient. You can do online care. I'm doing close to 10 to 15 online consultations every day, and that's just liver work. And my infectious diseases expert at Medanta Hospital, with her team, of course, of around 10 people, is taking care of 240 patients. 240 patients of COVID. She's not physically seeing every patient. They're doing online consultations. Now, similarly, there is a system called eICU. You can actually have a central console, and a single intensive care expert can manage up to 60 to 70 ICU patients just sitting on their console. So, those things need to be called in. Technology needs to be lent on and used and utilized. And that's how we're going to actually build the capacity of taking care of patients that's going to come our way in the next 6 weeks.
Well, it's a race against time. It's a race against time, and it is one we really can't afford to lose by trying to suppress the number of cases and hold doctors back from writing prescriptions for tests and penalize labs for testing and not wanting those numbers to rack up. Sticking our heads in the sand is definitely not the way to go. Thank you so much to both of you for joining us on The Big Story. And in fact, the warning to stay safe comes from the World Health Organization as well, that has said late last night, that we're far from over as far as the COVID pandemic goes. They've also now figured it out that asymptomatic patients may not be the ones who are largely spreading the disease. Take a look at this report.
Traffic is back on the roads in India, and offices, malls, places of worship are seeing people after almost 75 days of a lockdown. However, India is adding almost 10,000 COVID positive cases every day since a week. The World Health Organization says, don't let your guard down just yet. This is not the right time for any country to take its foot off the pedal because the pandemic is far from over. This is especially true for India, as it has added over 64,000 COVID-19 infections to its tally in the first week of June itself. Mumbai is now the first Indian city to record over 50,000 cases. Maximum City is soon going to cross the tally of China's Wuhan, which was the first epicenter of the pandemic. Meanwhile, national capital Delhi is examining the possibility of community transmission, even as the Modi government has ruled out its occurrence in India so far.
It still appears to be rare that an asymptomatic individual actually transmits onward. What we really want to be focused on is following the symptomatic cases. If we followed all of the symptomatic cases, because we know that this is a respiratory pathogen, it passes from an individual through infectious droplets. If we actually followed all of the symptomatic cases, isolated those cases, followed the contacts and quarantined those contacts, we would drastically reduce. I would love to be able to give a proportion of how much transmission we would actually stop, but it would be a drastic reduction in transmission. If we could focus on that, I think we would do very, very well in terms of suppressing transmission. But from the data we have, it still seems to be rare that an asymptomatic person actually transmits onward to a secondary individual.
The WHO recommends governments to continue focusing on detecting and isolating infected people with symptoms and pushes for increased contact tracing. Experts say the new finding is tough to believe without concrete evidence. India is now the 5th worst hit nation by COVID-19, which means that even though unlocking of economic activities is underway, we must be relentless in our fight against the pandemic. Countries can learn a thing or two from New Zealand's Prime Minister, Jacinda Ardern, who broke into a little dance when she knew that her country is COVID-free.